Good morning, everyone. It's my pleasure to welcome you to our webinar, HIV Awareness, the HIV is Here campaign from 2025 to 2026. My name is Ella. I'm pleased to be welcoming our speakers today. This webinar is taking place on January 14th, 2026. We are recording the webinar today so that we can share it with people who are not able to attend. This webinar is organized by the Manitoba HIV-STBBI Collective Impact Network. This is a network of innovators working collaboratively to transform the landscape of HIV and STBBIs in Manitoba. We bring people together to tackle complex HIV and STBBI systems barriers, and we seek systems change by shifting the conditions that are holding the problems in place. I'm speaking to you today from Treaty 1, Winnipeg, Manitoba. We acknowledge that we work and gather on the original lands of the Anishinaabe, Ojibwe, Cree, Oji-Cree, Dakota, Lakota, Inuit, and Dene peoples, and on the homeland of the Métis Nation. We are humbly working together toward the Truth and Reconciliation Commission's calls for action and the missing and murdered Indigenous women and girls inquiries calls for justice through our research, events, and projects of the Manitoba HIV-STBBI Collective Impact Network. If you would like to find out more about the Collective Impact Network, sign up to receive our newsletters, or find our social media and YouTube page, you can do so at cinetwork.ca. This webinar is part of our ongoing efforts to provide HIV prevention education, and you can find past resources on our YouTube page. We will have a question and answer period after the presentation today, and we're going to use the Q&A feature. So I ask that you type your questions into the Q&A feature, and you can type your question at any time. We will hold questions until the presenters are ready to take those questions. So as I said, it's my pleasure to introduce our presenters today. We have Dr. Sarah Lesperance, who is a public health physician who works as a medical officer of health in the areas of healthy sexuality, harm reduction, and substance-related health at both the provincial and WRHA regional levels. She approaches her work with a background in equity-focused health policy and a focus on the social determinants of health. Joining us as well is Paula Migliardi, who is the program specialist with healthy sexuality and harm reduction, population, and public health. Paula has a background in anthropology and has over 2 decades of experience in collaborating with diverse communities in community-based research and program evaluation. Her main areas of interest include sexuality and sexual health and harm reduction. We also have today Kim Bailey. Kim Bailey has a master's in social work and over 30 years experience in the areas of community and sexual health with a focus on program development, leadership, and management. She has developed innovative programs in partnership with newcomers, indigenous peoples, 2S LGBTQ+ communities, women, and youth. Kim is passionate about issues related to health equity and harm reduction. So thank you all for joining us today, and I will let you take it away.
Super, thank you so much. Hopefully you can hear me all right.
Yes.
Okay, perfect. And I'm just going to do a quick test. If I advance my slide, did it change? Okay, good. I see nodding heads. Okay, thanks everyone for being here today. My apologies, while we present, I'm just going to turn off my camera, but I'm happy to turn it on again when we move into questions. Okay, to get started, I really appreciate having everyone here. I'm Sarah Lesperance, and thanks for that introduction. I have with me, of course, Paula Migliardi and Kim Bailey. What we're going to do today is we're going to describe the development implementation of HIV is Here. So this is an HIV awareness campaign that was developed in Winnipeg. And it was really developed in partnership between Nine Circles Community Health Center and the Healthy Sexuality and Harm Reduction team at Winnipeg Regional Health Authority. And it's been supported by several community organizations that are also have been involved in harm reduction supply distribution in Winnipeg. So what we're going to do today is we're going to share the HIV-related knowledge that we gathered from community members with lived experiences using substances and receiving harm reduction supplies, which really set the content and tone of our campaign. We're also going to talk a little bit more during this presentation around some of our promotion efforts, the outcomes we've seen to date, and our ongoing communication efforts in the context of what we see as a current HIV outbreak in Winnipeg and across the province. So what we'll do is speak to those things, but really wanted to take a pause to recognize that many of the voices that were represented here came directly from the community, and they've been quite engaged in this throughout the entire process. And so our hopes are that the campaign efforts that we're sharing today genuinely reflects the contributions and perceptions of the group that participated in providing that feedback. Okay, let's see if I can make it move here. Okay, perfect. We're on the next slide, is that correct? Okay, so what I want to do is I just want to start with a concept that's really foundational to understanding of how and why we approached this campaign the way that we did, the idea of syndemics. So this is a background and a concept that we're really familiar with in public health, and it's also happening in many of the communities that we're serving across the province. A syndemic really exists when we have two or more diseases or health conditions that tend to cluster and interact within a population. So, and oftentimes things like social and structural factors will also allow for these diseases or states to cluster. And when that clustering actually results in an interaction, it could be a biological interaction, a social interaction, or behavioral interaction, we tend to see an excess of the burden of disease and continuing health disparities as being part and parcel of the events that are occurring. In Winnipeg and across Manitoba, we're certainly seeing STBBIs, substance use, and stigma really clustering together. HIV in Manitoba is showing unique trends among populations at risk, including within indigenous communities, and has many links to substance use, including injection drug use, and often particularly methamphetamine injection, as well as homelessness, and other structural factors, including structural racism and barriers in access to care. So there's certainly a clear socioeconomic gradient, and we're definitely seeing this coalescence of the social determinants of health occurring particularly in Winnipeg's inner core. What this tends to mean across the board is a lot of pressure on our systems, whether that be within public health, housing, harm reduction, mental health, addictions, community service providers. And so we're all realizing that we can't really address HIV in isolation from the interconnected factors that face the populations that we're trying to serve and support. And so this is really the lens through which we had developed this campaign. One other thing I'd wanted to do, just as we're getting started, is give you a sense of the numbers that really drove our sense of urgency. Manitoba definitely has one of the highest HIV rates in Canada. In 2023, the rate of new HIV diagnosis in Manitoba was 19.3 per 100,000 of the population, which was 3 times the national rate of 6.1 per 100,000 of the population. Winnipeg particularly has seen consistent increases in HIV rates over the past 5 years, with 151 new cases in 2023 and 186 cases in 2024. And in 2024, those 186 represent almost half of the, a little over half, of course, of the about 300 cases in Manitoba in that same year. In 2024, Manitoba also became the leader in HIV. So this map that you're seeing here changed somewhat, with Manitoba racing ahead towards a rate of 19.5, ahead now of Saskatchewan at 18.6. And so when we shared this basic information with community members during our initial stages of the consultation, many expressed a lot of surprise at these numbers. And the lack of conversation that they were seeing and hearing in their communities about this issue. The sense was that people didn't really know that HIV was this bad in Manitoba, and there wasn't really a sense of widespread awareness. In many ways, what we were trying to do with this is have conversations around the ways that in some situations we'd seen the expansion of harm reduction services in community, but often as a result of the pandemic, more and more of these interactions had become more transactional. And we'd moved somewhat away from some of our pre-pandemic collaborative care models within communities most affected. And there became this sense that maybe there were gaps in knowledge about HIV education and HIV awareness. And so, although maybe the logic made sense in terms of what we were doing on paper when we were trying to address these large numbers, there seemed to be a bit of a gap, and maybe these efforts weren't actually effective or as effective as people had been hoping. So we wondered, what does the community that's being affected actually think or know about HIV? And what is it do they want when it comes to HIV information and support? So to address this, we really wanted to develop an HIV awareness campaign to increase knowledge and understanding within communities that were most vulnerable to HIV transmission, including women, indigenous people, those experiencing homelessness, and people who use injection drugs. And we really approached this as a blank slate. Like, we didn't really want to keep doing what we were doing if it wasn't effective. And we really needed to start from scratch and let community voices guide us. And so that's really what HIV is Here became. It's a community-driven campaign that was built from the ground up based on what people told us they needed, not on what we assumed that they needed. So in late 2024, Healthy Sexuality and Harm Reduction in 9 Circles Community Health Center started collaborating to create a local HIV awareness campaign. Leading for Impact was significantly involved in conducting the consultations with the community, and House Fire's Design was a fabulous group that worked to support the illustration and creation of our design products, and you can see more of those as we proceed and talk today. So this really wasn't something that was developed in isolation, and really most importantly, the focus was the community voice, and that remained the center of this work throughout our efforts. So what I'm going to do now is just walk you a little bit through some of the consultation process, because this is really what gave the campaign its credibility, I think, and its direction. So Leading for Impact, formerly known as Health in Common, led all of the consultations that we conducted within community. This group has been working with communities, organizations, and governments since 2007 and has a really strong reputation for quality planning and evaluation services. So with their support, we held 6 focus groups across 5 different community service agencies. 2 of the groups that were held were specifically with women and gender diverse peoples. And then in total, there were 56 community members who participated. So you can see the listing of the 5 locations where these focus groups were held: 2 at 9 Circles, 1 at the Match Peer Leadership Group, 1 at North End Women's Center, 1 at Nidinaway Mac, and 1 at Street Connections. So in total, 56 community members participated, 33 of whom were women, 23 of whom were men. In addition to this, we also held a focus group with 11 service providers from a broad range of organizations that distributed harm reduction supplies in Winnipeg. And in addition to that, 21 service providers completed a survey about their supply distribution practices and their own capacity for HIV and STBBI education. And what they told us really was important in terms of shaping some of the conversations. People spoke about how distribution mechanisms varied widely, with some sites offering supplies on site and others doing them in terms of a community outreach model. And there was a variety in terms of the education capacity findings that were described in this survey. 6 sites said that little or no training was provided, and some offered harm reduction education for staff or found that their staff was capable, but in some situations there was very little training available. And so what we did see was that there was there was capacity, but it was uneven across the sites. And so really these findings helped to inform some of our campaign development and some of the conversations that we were having with the community. But in total, this didn't really stop at these community consultations. Once we started to develop the design for the awareness campaign and the posters and the other materials, we went back to the community with these design proposals. And so from there, 2 more focus groups were held with 9 participants in total who reviewed the draft designs. And then members of the 9 Circles Harm Reduction Peer Advisory Group joined the WRHA and 9 Circles to discuss a really revised version. So it evolved over time. The images that you see weren't the ones that we began with. And so final design was fully approved in discussion within this group. And so for us, this whole approval process really mattered. If the campaign was going to work, it really needed to be shaped and improved by the people that would be most affected. We weren't going to launch something into the community that the community didn't endorse. So from these conversations, 11 major themes emerged. What you'll notice is that knowledge and awareness were only part of the picture. People talked extensively about additional things, including stigma, organizational practices, structural barriers. And so this reinforced our syndemic understanding that you really can't address HIV awareness without thinking about and understanding the context within which it occurs. So in terms of perceptions of HIV, here's what surprised us to some extent, even though perhaps it shouldn't have. Many people still associate HIV with death and with it being a quote unquote gay disease. There was a lot of focus on sexual transmission as a source of HIV and less so drug use. Even though when we asked directly around sources and opportunities for HIV transmission, people did speak about needle sharing, and so there was that understanding. Despite this basic awareness of HIV, people also emphasized that they wanted to know more and they wanted some clarification in terms of risks. So there was knowledge, but it wasn't necessarily connected with the practices that people described. And so that gap is some of what we were trying to address and think about. When we look at HIV in Manitoba, and when we shared Manitoba's rates, remember, the 19.3 per 100,000 of the population in Manitoba compared to 6.1, so more than 3 times the national rate. Many people were shocked. There's no conversation about this, people told us. People mentioned that at the supply distribution sites they visited, that HIV was barely mentioned. And they felt that stigma really was creating a barrier before they were able to ask for help. There was a lot of judgment and misperception around HIV and being HIV positive, or even just asking about HIV. And so what we found was that there was that sort of lack of awareness around the high rates, and a lot of shame preventing people from seeking more information. And so, and again, this was one of the issues that we were trying to address. So when we look at some of the feedback themes and hear the voices from community, we see things like mention that a lot of people find out they have HIV and they give up. They think it's a death sentence. People said, mostly I think of the 90s, sex ed classes and homosexuals. I don't really think there's enough education. It's more like a taboo. I think that other drugs and other things have become bigger, and we've kind of forgotten about HIV. It's really hard to talk to people about taking an HIV test. They're not even aware that it's an issue in their community, according to a service provider. And again, from service provider, there's absolutely zero awareness campaign. Like nobody is aware of the fact that this is a problem. So when we took a little bit beyond and started looking at harm reduction supply distribution, People told us that supplies are accessible, which is good, but they would describe the interactions they had when accessing harm reduction supplies as being very brief and very transactional, almost like, take your supplies and you're done and off you go. So none of this was meant to be blaming of any of the work of frontline staff. Capacity constraints are real, and all of us are working to the best of our abilities. But community members still said that one-on-one conversations or group education sessions might actually be helpful to add to that knowledge and that awareness. And so recognizing that people want more than just supplies, that they want information. But on the other hand, people tell us that they prefer to take supplies and then go and don't necessarily want to have a long conversation. So the dilemma becomes then, how do we provide education without creating barriers to access? So community gave us a bit of clear direction. They mentioned that they were interested in workshops and education sessions potentially being held at existing service sites, and not necessarily going to new places. Brief interactions that could be held during supply distribution, with just consistent, clear messages, were considered helpful. Um, and many peer-to-peer outreach opportunities were described as being useful, or even pop-up clinics. And so the goal was really to meet people where they already were, with messages that could be quickly absorbed. And so again, this feedback really shaped everything that follows. This slide captures a bit of a, oops, and it hasn't moved there. Let's try that again. There you go. So this slide captures a reality that everyone, really understands. Distribution mechanisms will vary across organizations, and the general sense of capacity of HIV knowledge will also vary amongst organizations. And keeping staff updated is really challenging, especially when workloads and policies can sometimes limit professional staff development time. Primary care providers don't always have the opportunity to consistently offer testing and harm reduction education. These aren't necessarily individual failings, they're really system and capacity issues. And so even though this campaign alone really can't fix this, the goal is recognizing that awareness is really a start. And so when we saw and looked at organizational practices, we saw certainly that distribution mechanisms varied. Some locations had dedicated times during the day for drop-ins. Others had supplies available during operating hours, but only on request. Many interactions were described as face-to-face rather than self-serve, which is good because it means that there's more opportunities for conversation. And then some also had a combination of some self-serve for certain items, while others needed to be requested and had that opportunity to talk more. Again, that capacity, comfort, and knowledge around HIV was varying from place to place and from person to person. And so some of the discussions we had around capacity really focused on strengthening the efforts of primary care practice to ensure that providers were able and remembered to consistently offer HIV testing and harm reduction education during their routine visits, talking about things like transmission routes, access to condoms, PrEP and PEP, and sterile needles and harm reduction supplies, and where to get these things. Again, we did hear and understand that keeping staff up to date on HIV trends and developments was certainly challenging. Different organizational policies could limit the time available for professional development, and there were ongoing opportunities for formal learning, which may exist, but they still required a lot of support from leadership to be enacted. Again, in this area of thinking about prevention, we did hear voices from the community, and some of those are as follows. So I noticed that people know more about the bubbles than they do about prevention. They know where to get the bubbles from, but they don't really know why, as the voice of a community member. That is something that no outreach worker has ever told me. Yes, they told me to tell they told me never to use the same sharps, but never because of HIV. I think it would be beneficial if they had a little bit more classes on HIV too. A lot of people don't like coming to shelters. They're used to being on the street and they don't want to go inside somewhere to get information. So there needs to be something more mobile. They should have more information in the community and more workers in the community for drop-in to have that information. Being able to have a welcoming space where people are invited to spend time and sit doing things in a relaxed way together as equals. This is really what's needed, according to a service provider. And from another service provider, I think that really solid models are peer distribution. We can have all the spaces in the world, but peers going into different spaces where we just can't reach folks is crucial. So the next area that we started to look at were some of the prevention strategies. And we talked a bit about print media. So this is where we saw an interesting tension start to emerge. So community members on one hand were clear to put print materials in every sort of harm reduction kit and wanted something informative, colorful, and engaging. One person said to us that I think that pamphlets would be a good idea to have inside the kit so that people can read it. And another community member told us, if I see a poster, especially if it's catchy color and everything, I'll read it. People also suggested branded items like keychains, chapsticks, and lighters, things that generate interest and direct people to services. But on the other hand, we found that service providers gave us a slightly different perspective. They told us that they see that people show little interest in brochures, that distributor products tend to just end up in the garbage. So trying to balance this tension and understand and think about, who's right in this decision in terms of what we're going to do with print media. And it was clear that probably both sides made sense. Print materials had the potential to work when they were designed in a way that the community asked for them. So not dense information sheets, but visually engaging and brief, something that you can read in the moment and keep. And so that's really what the campaign tried to create. The key messages were easy to agree upon. Community members and providers agreed on this. The focus needed to be on destigmatization and normalizing testing and information around HIV. Multiple groups and people we spoke to recalled the I Love Somebody Who Uses Drugs campaign from Manitoba Harm Reduction Network and spoke really positively about that and suggested similar messaging for HIV. People wanted to have things that alleviated their fears, to normalize testing, to increase awareness about available treatments, and that really became the focus. As for non-print media, things like social media, radio, TV, these really came up less frequently in our focus groups, but when they did, people emphasized that the need was to target specific audiences, to think about radio in rural and northern Manitoba, and to use online ads that may be accessible on public computers at libraries and at shelters where people may not have personal devices. And so in the end, we really took that multi-pronged approach. So print became as foundational because community asked for it, but also bus shelters, social media, and provider outreach to reach individuals through different channels. Again, when we talked about and thought about the theme of HIV risk, three populations really emerged as particularly vulnerable in our conversations. Youth, many youth were described being reluctant to approach staff for fear of judgment. People felt the need to provide HIV education through schools. And there was also an identification, and this was a quote, that there are certain groups of young kids that use needles and pipes, but they will not go and ask for clean pipes and needles. So the urge to actually have a safe space that they already may be accessing to share some of this information and supplies was emphasized. When it came to institution, we definitely heard, and you see this quote here in terms of shelters confiscating clean needles. It really brought forward how institutionals can shape and influence people's access to and increase sort of their risk in terms of HIV. So one participant mentioned that some shelters take away all the clean needles. The policy is no drugs here, but there are drugs getting in there. But still, they take away all the clean needles, so the risk is increasing. A few participants also noted the risk for people who are incarcerated, as prisons prohibit access to clean or sterile harm reduction supplies, which can lead to high risk of HIV transmission within the prisons themselves. Women, were also identified, and female identified individuals were also identified as members of vulnerable groups. So conversations revolved around gender-based and intimate partner violence, which could increase the risk for women and gender diverse peoples. And female participants spoke about their own limited knowledge of HIV. Some female participants were only made aware about HIV when they were tested after being sexually assaulted or through rapid testing outreach. And notably, in our conversations, any mention about having access to rapid testing came from our female participants. So when we also spoke again about HIV and HIV risk, HIV-related stigma came up in all of our focus groups as a real barrier to accessing services and to adopting prevention practices. So in terms of barriers to seeking care and testing, outreach with a focus on HIV education and support in encampments and other locations frequented by people at risk was needed and was recommended. People felt that there was a lack of awareness of available services, or that people may be reluctant to enter an unfamiliar establishment to ask questions or to seek resources. There was also a fair amount of stigma and risk. Oh, sorry, I didn't advance the slide. So there's also a fair amount of stigma and risk associated with substance use and addiction. Participants really noted their fear and shame of asking for help or asking a partner to practice harm reduction, felt that it would get, and these kinds of things, this fear could get in the way of prevention. There was a recognition that sharing information about HIV needs to balance messages about the urgency of the current state of HIV in Manitoba, while simultaneously offering a message of hope that normalizes HIV as preventable and as a treatable STBBI. And so some of these quotes really captured the reality. People spoke about how when people get high, they want to share, meaning that it's hard to think about HIV prevention in the moment. On the other hand, people said that, if you've been waiting all day to get high and you're in the moment and you don't have a clean needle, you're going to use a dirty one. And so some of the conversations began about how do we think about interrupting that in the moment to bring back that awareness of HIV and HIV transmission risk in those crucial instances. Again, people mentioned these barriers and that people are self-conscious about asking about prevention because they think, oh, they're going to assume that I'm dirty if I ask them about harm reduction supplies or I ask them about HIV. So given everything that the community told us about stigma and shame, what did they really want from the campaign itself? Well, the message was clear, warm, compassionate, and positive. No alarming messages, a focus on the idea that HIV is manageable and support is available. The emphasis was on bright colors to show people together in community, not in isolation, and critically to provide print materials in every harm reduction kit. They really wanted something tangible they could take with them, read later, and share with their friends. And this really shaped our entire visual approach. In the end, we launched the campaign last summer with materials to all of the partner sites. The website was set up with prevention, testing, and treatment links. In the fall of 2025, the bus shelters emerged, which were highly visible, and the goal to normalizing HIV and conversations around HIV, emphasizing that it's here and present in Manitoba in our public spaces. And also social media campaigns. And again, in the fall of 2025, through the Winnipeg Regional Health Authority, the Healthy Sexuality Harm Reduction Team, as well as 9 Circles, social media at the same time. Letters to primary care providers within and to Winnipeg Regional Health Authority sites went out in September of this year, of fall 2025, as well as Doctors Manitoba reached potential providers throughout the province in December 2025. The goal was really to saturate multiple channels simultaneously so people would encounter these messages repeatedly and within different contexts. So where do we go from here? Really, everything now is available at streetconnections.ca/HIV. You can download materials including posters, copies of the report, and information that you can share within your own networks. The materials that we have can also be adapted to include local service information. So there's a copy of a poster. If you want to add stickers and more information linked at the bottom of those posters, that's totally possible. No problem at all. And we're really committed to continuing work. So for us, this isn't really an end stage process. What we've shared to date is really just part of a broader evolution. And so community engagement is ongoing. Some of the materials and information that's been created and developed within this campaign have been shared within Winnipeg with a group called SORT, which is the substance-related and STBBI outbreak response team, which is a coalition of community members, Winnipeg, which has taken some of this information and prepared messaging and shared this with the province. So really use these efforts and these learnings in an advocacy manner to really bring forward that voice to the province that HIV really is here, and we want to see more conversations about it. So in addition to that, we will continue to maintain a sense of trying to understand how, in fact, this is being effective in community, how it can be reshaped and adapted as those findings emerge, and what kind of additional products we could include. Again, these being really based on community feedback and recommendations, as well as expanding beyond the partnerships that we have to date. And so having different voices and different community groups taking the lead in different ways. And so really what we're looking for is, any of the engagement of the SIN network or SIN membership in terms of supporting and helping to share this information, because really this is the goal, that more and more people are talking about HIV, more and more people are aware that it's here and it's present in Manitoba, and that there's support and care available. So with that, I will end off this sort of formal part of the presentation. And we can open up for questions. Alternatively, I might turn to my colleagues here, Paula and Kim, just to see if there's anything that you wanted to share in these latter part stages of this presentation, just to emphasize or that you feel I might have missed.
You did a great job, Sarah.
Okay, well, that's good to know. We will then open it up to questions. A copy of this presentation will be available to you, so you'll be able to have all of our contact information if you'd like, as well as we'll make sure that some of the other materials that we have are shared with you. And I'm not sure how that works officially, but I will leave that over to you, Ella, and to the team. And I will stop sharing now and open up for questions.
Thank you so much. That was a great presentation. Um, we have about 50 people joining us right now. So for everyone joining us, please feel free to put your questions into the Q&A feature, and that's what we'll use to answer those questions. I'm also going to pop into the chat a survey. It's a very short survey just to let us know how we did today, and that just helps us to continue providing good quality webinars and for continued funding for this work. So I'll pop that into the chat. Feel free to check that out. And again, put your questions into the Q&A. We have one question so far. Question is, who created the visuals and campaign branding?
I can turn that over to you, Paula, but it was really Housefire's design and illustration that was involved. And I can say for sure that they were quite it was a really iterative process. It wasn't one design. We started with one and it was brought back to the groups and then changes were made. Some of the initial designs were rejected because they didn't have that sense of community. They didn't have that sense of positivity that was wanted. But I'll turn again to Paula and Kim to add in a little bit more because I know you're much closer to some of that work.
Yeah, thanks, Sarah. Thanks for the question. Yes, Housefire had to work with us in several products that we have developed over the years, and effectively they participated in conversations with some of the community members to get to the point that the look and feel for the campaign was something that matched what people were looking for and were interested to see circulating in their communities.
I would
Thank
say
you.
the Nine Circles peer advisory team played a really important role in sort of vetting and shaping and giving some good advice to us around the meanings of certain things. I think one of our original ideas was to put a thumbs up next to the HIV, what's it called? The is here get tested, where we have hard hands now. And that came right directly from our peer advisory team, because the thumbs up had a number of different meanings in terms of in terms of some of the street involved populations. And that was a real shift because of that feedback from one of our peers. So that's definitely came from them, and it ended up being a really excellent addition to the campaign.
Thank you all so much. Another question here. Can you talk a little bit about U equals U? And specifically, this person is asking about, in terms of U equals U, passing HIV onto a baby during pregnancy or delivery. In some of the education pamphlets, it's noted that a person will not pass HIV to a baby during pregnancy or delivery, and this person is just wondering if that's definitive. So maybe you can just talk a bit about U equals U and some of that piece. Thank you.
I guess that one's for me. So really, U equals U is the idea that if it's something, if something is not detectable, or if our HIV viral loads are quite low, we have a really reduced chance of transmitting that to someone else. And so what the goal is often is that we try to ensure that anyone who's HIV positive has access to support and has access to medical care and treatment for HIV. And if they're able to adhere to that treatment and keep their viral loads low, it's very unlikely that they will transmit it to others through sexual contact. Sometimes the risks and concerns around transmission, U equals U, don't always apply to needle sharing. And so in those situations, we tend to advise a little bit differently than just the standard U equals U. The other situation you asked about with transmission to a fetus during pregnancy also follows the same principles, in that if someone is well treated and managed throughout their pregnancy, it reduces their chance of transmission to the fetus. I wouldn't say it's as extreme as U equals U entirely, because we still would want to be very, very careful and cautious around transmission during pregnancy. And so multiple sort of additional safeguards would be part of that pregnancy, ideally, to ensure that we don't have transmission from mother to fetus. But with good, positive, supportive care and very low viral loads during pregnancy, we can significantly reduce the risk of that being transmitted, certainly to the fetus.
Thank you so much. Another question here. If there are community members or organizations who want to partner in prevention and community engagement projects, how can they get involved, or who should they contact?
I'm assuming that the questions are about prevention. One of the things that I think that would be really, if someone's involved in Winnipeg, we do have a STBBI sort of outbreak response team that we do talk a lot about these prevention efforts within the community. This is sort of held through the Winnipeg Regional Health Authority, although the Winnipeg Regional Health Authority are not the leaders of this. It's really a community-based group. So becoming involved in something like our SORT group in Winnipeg is one option in terms of being part of the conversation. Certainly, there's multiple other networks, as you know, being part here of SIN, which is a key component of a lot of those outreach and prevention efforts in the province. If a group or individual is looking to be part of some of the harm reduction messaging and some of the prevention efforts, and some of the work that we might be doing, for example, through Street Connections, and I can't quite speak to your work, Kim, and I'll leave that to you, but through Street Connections, certainly we do have participations with a number of harm reduction supply distributors. And whether or not we have opportunity to expand our harm reduction supply distribution is dependent on sort of multiple things, but at the same time, we still have an awful lot of information that we can share and contribute if anyone's interested in having those conversations or trying to enhance some of the prevention messaging that they're sharing. And I think that, to me, is a start, right? I think the conversation is the essential beginning, and being here and being aware. Accessing the webpage link that we have here will also link you into a number of other supports and resources, and other individuals and groups that are having those prevention conversations. So really, really great question. Really, really happy you've asked it, because that's really the next step.
That's great. Thanks. And I'll make sure to include all of our contact information, including my own, in the follow-up email in case people want to get in touch. The next question we have here is, could you speak on access to PrEP and PEP in Winnipeg/Manitoba? What are some current challenges?
So the great thing about PrEP and PEP in Manitoba is that they're available. And that they're broadly accessible. In the past, PrEP and PEP are used in different ways, whether or not we're using them before someone has access to contact that might increase their risk of exposure to HIV. And that's kind of what we call the PrEP, or the pre-exposure prophylaxis. So it's taking medications that will reduce your risk of acquiring HIV through contact. And then PEP, post-exposure prophylaxis, is something that people can use after an exposure of concern, where they're really looking to prevent the development of HIV. And so these meds, if they're used consistently, are really effective in decreasing risks of HIV transmission. The good news, as I said, is that they're available. And now they are available to individuals within sort of the pharmacare program, so that there isn't an additional cost or expense to acquire these medications. There's also not the same barriers that we may have had in the past, where it was often presumed or assumed that someone needed to be a PrEP provider and had to register as a PrEP provider to be able to prescribe these medications in community. Some of those limitations and restrictions have been lifted, and so now PrEP and PEP prescribing is open and available to anyone who's interested in doing so through their practice or their care of individuals and communities. There's a lot of really great information available online through the Manitoba HIV program in terms of ways to things to think about in terms of prescribing, and guidelines and assistance and support for anyone who may be looking to do so. And so certainly the barriers are down. I think in some ways it's just the knowledge, and the awareness of the availability of these medications, and the effectiveness of these medications and interventions is where we're still lagging a little bit behind.
I think there's some challenges in terms of similar to people who already have HIV, and because of all of the sort of syndemic structural barriers that exist to maintain connection to healthcare and healthcare providers, and making sure that you're taking your medication every day and that kind of thing. That challenge exists in the context of PrEP as well, because it's currently, I think, pretty much a daily pill that you have to take. So first of all, you have to recognize that HIV is here and is a problem, and be motivated to take your medication there's an awareness that has to happen, which is part of the motivation behind HIV here in Manitoba. So when we've looked at future iterations for this campaign, currently the emphasis is in terms of the hard hands is around getting tested, but it can also be expanded out to getting PrEP. People have to understand that, again, that there's a problem to be solved, and here is a solution that you can use. There's also some of the similar barriers around being able to hold on to your medication, remember to take it every day, some of that. And I think, as I understand it, there's some innovations coming in the PrEP world where it's possible, not available yet in Canada, but hopefully in the next number of months. There's an injectable, so that would last for 6 months. So it would require like an injection every 6 months. So that everybody talks about that as a game changer. And but still, I think part of the challenge will be that people will have to be motivated to do that. And that's part of the conversation about why we want to raise awareness that HIV is here. So, yeah.
Thank you both. Another question here. So this question is about considering the difficulty in, on the one hand, conveying the severity of HIV, and then on the other hand, the importance of not further stigmatizing HIV. What are potential ways we can navigate that in our messaging? To clarify, we want to convey that HIV is a serious chronic illness that should be avoided without contributing to the stigma of people who do become infected. Since these populations face such high risk levels in their day-to-day lives, for example, with violence, drug poisoning, persecution, etc., I feel risk itself becomes normalized and HIV transmission doesn't supersede other kinds of risk.
Yeah, that's a really, really, really good point. It's often a situation that all of us that are working in the field, we wrestle with on a regular basis. So we certainly don't want any of the messaging to become more stigmatizing. And I think that sort of breaking down and thinking about what we mean when we think about something as being stigmatized or stigmatizing is really that presumption and assumption of sort of expectations around how someone should behave based on that sort of capsule of information that's surrounding that idea. And so, in a way, breaking down the stigma involves a couple of things. It involves enriching the conversation, so bringing more layers into it than just simplifying it and saying it's, this population and this individual and these exposures, and actually enhancing sort of a broader understanding of the multiple sort of and the complexity of individuals and their lives and their experiences in relationship to HIV. And so that's one of the elements I think where we break down stigma. I think really just that idea that we're talking about of normalizing it and normalizing it as a serious health condition and as a condition that requires support and care and compassion and understanding of all of the other contextual factors that come into play in the same moment that you're trying to address and support an individual. And I think that by enhancing that understanding of hearing more of those voices and the stories from community and the successes in terms of those that are able to find support through the structural and social determinants of health that are making HIV care so challenging, or some of the ways that we change that narrative. Because in a way, stigma really is a narrative, and it's a negative narrative. And I think that that's some of the way that we address and change negative narratives, is by enhancing that. I think it's like anything else that we deal with in society where there's stigma attached, whether it's injection drug use, whether it's HIV, whether it's someone living in a houseless situation. I think it's approaching those conversations with curiosity and care and compassion, and really just trying to emphasize and think about the person in front of you and what are the hardships and experiences in their life that have brought them to where they are. And I think that that's a challenge, and that's something that we can each do one-on-one in a harm reduction way. And then I think with time, collectively, then that starts to become the energy that we as a society and a community are actually approaching these really, really challenging conversations and experiences in people's lives.
Thank you so much. Uh, there's no other open questions at this time. Um, I will give the people on the call one more minute in case there's any final questions for our presenters. And not seeing anything come up, I just want to thank all three of you for your time today, and for sharing your expertise. I'd like to thank everyone who's on the call and for your great questions. Again, I will send out all of our contact information for people on the call or people who are watching this recording who would like to get in touch. We'll make sure to include that in the YouTube video. And thank you all so much again. Hope everyone has a great rest of their day.
Thanks so much for the opportunity.
Thank you, everyone. Have a good day.